My name is Elton Tidwell, and I'll be presenting an evidence-based review on the effects of virtual reality on balance in stroke. So first, let's go ahead and define what a stroke is. A stroke is the sudden loss of neurological function caused by an interruption of the blood flow to the brain. Pretty standard definition. And some of the symptoms that are attributed to balance are paralysis of the upper and lower extremities, impaired tactile and proprioceptive sense, cerebellum or inferior cerebellar peduncle dysfunction, vertigo, nausea, vomiting, sensory impairment, tetraplegia, paralysis of conjugate gaze, ataxia of limbs and gait, as well as diplopia on lateral gaze. So reduced balance control can lead to a sedentary lifestyle, limitations in ADLs, low self-esteem, depression, social isolation, and physical deterioration. So it's pretty clear that rehab regarding balance after a stroke is pretty important for somebody's life. Common rehab considerations are, in the acute phase, early mobilization. So this can do a lot of things, such as prevent harmful effects of bed rest, increase the patient's consciousness, promote functional reorganization, minimize learned non-use, reduce mental deterioration, depression, and apathy. Common interventions are positioning, functional mobility training, ADL training, range of motion, and splinting. And we want to educate patients and families on the pathophysiology, impairments, and activity limitations, risk factors after a stroke. In the subacute phase, patients usually enter intensive inpatient rehab, which consists of around 6 days a week for greater than 3 hours of active rehab. If the patient needs less intensive rehab, they're usually transferred to a transitional care unit. So in the chronic phase, there's a continuation of inpatient interventions, along with constraint-induced movement therapy, bilateral training, virtual reality training, and electromechanical assisted walking. So as you can see, virtual reality training is bolded because that's what this presentation is about. What is virtual reality? The review defines it as the use of interactive simulations created with computer hardware and software to present users with opportunities to engage in environments that appear and feel similar to real-world objects and events. Okay, so what is balance? Balance is vision, vestibular, and somatosensory systems working together to provide feedback for corrective torques. How can virtual reality help with balance? Well, it can provide augmented feedback about performance, visual, vestibular, and somatosensory input, which directly relate to balance. It enables individualized repetitive practice, and it stimulates motor and cognitive processes. So here's the review that I'm presenting. It's by Lee et al., 2016, and there's the name of it in case you want to pause and pull it up while I'm presenting. So the methods were, sorry for all the text, I'm just going to go through these bullet point by bullet point. They accepted RCTs examining virtual reality on balance post-stroke. So there were no inclusion restrictions based on age, gender, or disease duration. They narrowed down 16 studies. 5 used the Wii Fit, 3 used something called the Gesture Tech IREX. There was 1 telerehab paradigm, as well as some treadmill virtual reality programs. And here's a video I have on the IREX, just to give you an idea of what it looks like.
In the next 3 minutes, you'll discover a therapeutic advance that will actually help to build your practice while it promotes exercise compliance. IREC, the Interactive Rehabilitation and Exercise System, is essentially a software-enhanced computer system that involves patients in a therapeutic exercise regime while they watch themselves on television as a key player in a video game. Used by a growing number of physical therapists, the IREC.
Okay, so that gives you an idea of what that looks like. And again, that's the IREX. Most of these studies were performed within 2013 and 2015, between 2013 and 2015. There were 4 in the subacute and acute phases and 12 in the chronic phases. So as you can see, the chronic studies highly outnumbered the acute and subacute. So study quality was assessed by Cochrane's risk of biases tool. And so they look at random sequence generator, allocation concealment, blinding of participants and personnel, blinding of outcomes, assessment, incomplete outcome data, and selective reporting. So for each criteria met, they allocate 1 point. For a study to be considered good, it has to have 3 or more points allocated to it. So the control in most of these studies were conventional physical therapy, and 2 used treadmill as their control. Primary outcomes include the Berg, Brunel, Tinetti, the TUG, functional reach test, and the ABC scale. Secondary outcomes were force platform measures, which are center of pressure, sway velocity index, weight distribution, and there was they measured adverse events and therapy adherence. Mean differences were assessed with a 95% confidence interval, and heterogeneity was assessed as well. So here's a little flow diagram about how they got to their 16 studies they included. They started out with something like 1,150 and eventually got down to 16 they were happy with. So the results were that most interventions last between 3 to 6 weeks. There were significant improvements in the Berg and the TUG, as well as the functional reach test, although there were only 2 studies looking at this, and they had a high level of heterogeneity. Same goes with the ABC scale. There were only 2 studies, again, high level of heterogeneity. There was no significant difference in sway velocity and weight distribution. The force platform biofeedback only improved in stance symmetry. Here's one of the tables from the study. So on the left, you could see the reference. So those are all the individual studies they looked at. The next column over is experimental group. So that's what they use. So you can see WeFits in there, IREX, and some other various experimental groups. And it also shows the control next to it. So on the right-hand side, it'll show you the quality of the study and the key findings. So what improved? This is a useful table. I would come back to it if you want to think about incorporating virtual reality, because it also shows the dosage, and you can kind of correlate with that with the intervention and the key findings. And here's another table that breaks it down by outcome measure. So as you can see on the right-hand side, you have the mean difference and the confidence interval. So basically all those little green and black dots will tell you how much effect the intervention had. So the further they are to the right, more the experimental group was favored. So as you can see, the highest one was the Kirpik 2013 study. Had a pretty high difference there, but it did have a large confidence interval. All right, some limitations of the study were most of them had small sample sizes, and again, most of them were greater than 6 months post-stroke, so you don't really get a good idea of the effects in the acute phase. So interventions in the review varied significantly. So you had the WE, you had the IREX, and you had treadmills. So moderate methodological quality in most of the studies, and they assessed a younger population, so 46 to 66 years old. We don't know how a older person would be affected by this. And they didn't really assess long-term follow-up. So some implications for practice. So virtual reality might be beneficial due to its intensive repetition of meaningful task-related activities. It may improve balance outcomes significantly compared with standard physical therapy. And we have to ask if age is a factor. And for practical purposes, this IREX system, if I did my Googling correctly, it looked like it was $13,000, which is pretty steep. But I guess if you work in a research hospital, maybe you have one at your disposal, that would be great. And then the Wii is more practical. It's around $250 plus another $100 on Amazon, very easily attainable. So another good thing to do would be to break down the study effects by the system. So in other words, going through and looking, how did the Wii affect balance, and just breaking them down so you know how the IREX did, how the Wii did. And I think the big takeaway from this is the effect of making therapy engaging. That's what virtual reality is doing. It's making it salient and goal-oriented. And those are good concepts, even if you're not using virtual reality. So I put finger flexion versus shooting zombies on there. So I would much rather shoot some zombies than just do finger flexion. Okay. So, and I have a video to wrap this up. And this is just kind of shows you the direction virtual reality is heading. And you can kind of use your imagination to see kind of the rehab implications of this. So thank you for watching. And again, I'll play this video for you and go ahead and close out whenever you feel like you've seen enough.
Two on the terrace. Check that. 3 on you, Mitchell. Drop them. Take him out. Pay attention, Mitchell. Prophet, we're approaching the north access road. What's our exfil status?